Thank you. I feel very honored and thrilled to be here speaking today. I've been listening to the prior speakers, and it's been very exciting, and I can only agree with most of what's been said, and I hope I can bring some insights on how this will be done, because that's what I'm going to talk about. I agree with Jens, who said that there is no single silver bullet to do this. You have to have a very deep knowledge of what you do and an integrated understanding of healthcare where you are. But also I usually say that it's not rocket science. It's really basic, simple, everyday knowledge applied to the best of the patient. You have to have the view of the patient. This picture is a picture of some of my co-workers at Sahlgrenska University Hospital, taken in the central hall of the hospital. And my name is Barbro Friden. I am the former CEO of Sahlgrenska. I left a year and a half ago to implement value-based healthcare in the Middle East, so I have some of that experience with me too. And it's a pleasure to tell you a little bit of how this can be done, and maybe some of my experiences can be useful for you. I will start with this picture. You probably read all the ranking lists just like everybody does. There are international rankings of healthcare all over the world. Some of these rankings are really poor. This is one that I actually follow. They have been ranking hospitals and countries since 1990, and they rank 195 countries. And they do it by measuring medical outcomes for different diagnoses. So it's a thorough job. These are the results from the summer, published this summer, and the results come from 2015. As you can see, Sweden takes an honorable 4th position. We usually take one of the first 7 positions in any rankings and have been doing that for decades. And we're very proud of that, but there is no secret to it. I will tell you how we came about being so high ranked. In this case, I've chosen to show you this result because it illustrates 2 of the basic principles of value-based healthcare. As you can see, the 2 top countries are Andorra and Iceland. Both of them have less than 1 million people. Should be pretty simple to handle healthcare for such a small. It's not even Moscow. It's probably not even one of the suburbs of Moscow when it comes to number of people. But what these 2 countries do is that they send their highly specialized cases, the rare cases, to other countries, to centers that they have chosen to be the best in the world. And by doing that, just like Jens told us, they save money. And they produce good health care, and that's part of their ranking. Then they produce very good health care on the daily needs of the patients at home. The ones that need daily care or basic care, that they do very well. So that's one of the principles in healthcare. Pull your patients to the centers that do it well. The other principle is illustrated by Sweden, and that's that we measure the outcomes. We have been measuring outcomes for ages. And if you measure something, you want to improve it. As Martin just said, people working in healthcare are passionate about their patients. They don't care particularly about money or processes or industrialized medicine. They care for their patients. And if you measure outcomes, they always want to do better. And that's the secret why Sweden has been in the top for so long. We measure things. Here's another ranking list, which is ranking more of the administrative performance of different healthcare systems in the world. 11 countries participate. And as you see, Sweden comes pretty high on all these different parameters. But yet again, we come really high on outcomes because we're really good at measuring them. And this is really sort of the gist of what I'm going to say today. We do measure them. We publish them transparently to the world, not by individual doctors or individual health professionals, but individual departments and hospitals. So the patients know where to go when they need good care. And I can tell you, if healthcare professionals are, if nothing else, they are competitive. They're type A personalities, all of them. They don't want to be the last ones. And I'll show you some evidence of this. So why is it that we measure things so much in Sweden? Well, we always did that. But in 1975, a Swedish orthopedic surgeon had been working in the US, and he was inspired by Amory Codman's statements from the beginning of this century, actually from the late 1800s. That's when he started saying that we have to measure things in order to get better. He thought that his ideas would be actual and in place in a few years. We stand here 100 years later, still working on it. And I believe that the time has come now. He was way before his time. Now we have the instruments, the knowledge, and also the systems to do it, to do the things that he prescribed. But Professor Göran Bauer, professor of orthopedic surgery, came back from the US with these ideas, and he started the first registry in Sweden, the hip and knee registry. Hip and knees are pretty easy to measure. I know you know where they are, how many they are, and you know what's to be done. There are more complicated diseases to measure. And during the course of the years, Sweden have started registries for basically everything. I'm a physician, I'm a trained physician, and I know that any patient I take care of, the outcomes I put in the register. And that's in the heads and minds of all healthcare professions in Sweden. So now we have registries for basically everything. I can tell you that most of the registries contain a majority of process or process measures, not the outcomes. Some contain outcomes. But now, with ICHOM, we can use our sort of habit of measuring things and use the outcome measures that ICHOM produces, and this will increase the quality of care in Sweden very dramatically, I think, because we can now compare on equal terms. Just to show you a little bit of what outcomes can do, when Göran Bauer started measuring hip replacements, they learned very early on that by pooling all the data from the 10 million people living in Sweden into the register, they could very quickly say when a new prosthesis came out on the market, this is a good prosthesis, it's good for the patients, or it's a bad one. And that changed the behavior of the companies producing hip prostheses, because in 6 weeks in Sweden, we could say whether it was a good or bad product. Here's another example that was published in the Lancet in 2014, where they compared UK and Swedish care of acute myocardial infarction. And of course, the British doctors have the same medical knowledge and insights as the Swedish doctors do. The only difference between the countries were that we measured whether they complied to the best evidence and whether they didn't. England did not measure, and we produced these outcomes and published them transparently. If England had done the same thing during the years of 2004 to 2010, they would have saved 10,000 lives just by measuring. That's mind-blowing, isn't it? I would like to have my myocardial infarction in Sweden rather than England. England has changed, but this is a very good evaluation of what transparency and measurements can do. And furthermore, if you try, as you see here, these are a quality index that is produced by the myocardial infarction registry. It contains about 10 outcomes that they make into a quality index. And they measure different departments in Sweden. And as you can see, the better half, all hospitals improved their quality by 13% during the years of 2005 to 2006. But the bottom half improved slower than the rest. Then, in 2006, late 2006, in the Swedish newspapers, it became public which departments were good and which were bad. And as you could see, the poor performers were the one that improved fastest afterwards. I worked in a very close proximity of one of the poorest performers in the country, and there were no end of the explanations why their patients were sicker or why they have a harder time or less resources or whatnot. But after they came through all these explanations and started working on their process, they became the best in Sweden in 2 years. It didn't cost anything. They just used the knowledge that was there. So yes, transparency can be a very powerful tool. So, what did I do at Sahlgrenska University Hospital? Well, I started there as a CEO in 2012. I came to one of the biggest hospitals in Scandinavia, Northern Europe, and definitely the biggest one in Sweden. We have some 2,000 beds, between 16 and 17,000 staff. We operate on 5 sites, and as you see, we see a lot of patients every year. 1.2 million outpatients, more than 100,000 hospital cases, and more than 200,000 A&E cases. So it's huge. We also have most of the highly specialized commission care in the country, and we do teach all the medical professions in the academic collaboration with the university. And the turnover was back then about 16 million Swedish kroner, which equals about 1.8 billion euro. So it's a huge center. And for you who maybe don't know Swedish healthcare as much as I do, it's a socialized system where everything is paid by taxes, and the patients come to the hospital requiring the care and basically don't pay anything. And I think it's a very similar system here in Russia. Yeah. So I came into this humongous hospital wanting to do something good. What I did was that I diagnosed the hospital because the financial situation was stable. Not sustainable, but stable at the time I came in. So I thought, okay, I have the time to make a good diagnosis of this hospital before I start working. And I did. I could see that the medical results were decent, but there was certainly room for improvement. I could see that in order to reach this financially stable situation, they had done a lot of cost cutting. And that made all the medical professions really disengaged. They were not happy and did not follow the prior management. So I came into a very disengaged and very hostile group saying, okay, so you're coming here to cost cut too, are you? And I tried to say that we have to find a way together here to come in. And I could also see that the patients weren't present. And in discussions the first couple of months, we decided that value-based healthcare is probably the strategy we should adopt for our hospital where we stand right now. It may not be the answer for everybody, but it certainly was the answer for us. So what did we do? Well, we decided not to build the 10-tier big wedding cake, at once, but we started with little cupcakes, little pilots. Every cupcake is individual and different, so we actually used the cupcake sort of as a metaphor for what we were doing. So we wanted to start with small starts, and we wanted it to make it attractive to the working groups to become one of the pilots. And in order to become and be selected as a pilot, they had to build a working group with all the professions in them. And the most important profession to be part in the working group was the patient. No working group could start unless they had a patient in the group, because the patient is the ultimate specialist on the condition. We sent them to value-based healthcare school, so they had guides, and they were trained for 12 weeks before actually starting the work. And then we said that this is your budget, but within the budget you have great autonomy to do whatever you feel is needed. You have to identify where your weaknesses are and work on them. We will support you in any way we can. You cannot go outside your budget, but if you make a surplus, you get to keep it. That way we aligned their interest a little bit for economic things. And then we said that this is something we test, so we have to learn along the way. This was an evolutionary process. So we started with 5 or 6 groups, and I will show you a little bit later what happened. We could see that the first thing we have to do is measuring outcomes. The registries, as I said, contain a lot of process measures, how many, how often, how big, what color, but we needed to find outcome measures that mattered to patients. At that time, ICHOM wasn't around, so we had to figure out the outcome measures ourselves. And we did that together with the patients in intensive discussions with patients. What matters to you? What is it you want us to do? So we found outcome measures, not many, but some. And that was enough. You don't need that many KPIs. You just need some really good outcome measures. And by doing that, you have to start working, organize your care along the medical condition. It's not interesting to work at the lab. You have to work with, for example, stomach pain or hip pain or something like that. So you have to find something that is logical to the patient, a condition, and you have to see the whole condition, the whole episode of care. I usually think when I go and have my mammogram to see if I have breast cancer, I always think to myself, okay, now I may be starting an episode of care. And that episode of care may not stop until 5 years from now, because if I have breast cancer, I have to go through treatment. And first, after 5 years, we can evaluate how it all went, whether I'm okay, whether I survived, whether I have a good life. So you have to have the full cycle of care. And as Martin very carefully stated, you have to have the full team. You can be a brilliant neurosurgeon doing all these fantastic surgeries in the brains of people, but if the patient dies of septicemia because of a pressure ulcer later on at the ward, you missed part of the team, and all the values that could have been created is gone. So everybody in the team has to be present. We've heard about all these building blocks, but we found out that they actually are very valid, and you have to work with all these building blocks, but you have to start by measuring the outcomes. And what outcomes are we talking about? Well, on the left side of the panel here, you see the outcomes that we usually measure in the hospital as doctors, nurses, or whatever. HbA1c, for example, is a popular measurement to see how diabetes is handled. And of course, that's important to the diabetes doctors and nurses. And of course, it's important to the patient too. But the patient with diabetes wants to know whether I will keep my eyesight, whether I will keep my kidneys, and whether I will keep my feet. That's what they want to know. And in my hospital, we were given prizes every year because we were so good at keeping the blood sugar levels at a very stable. But we were one of the highest rates of foot amputation in the country. And as a patient, I would rather keep my foot than having a perfect HbA1c. And that's what the patient taught us. You have to look at what we want. So waiting time, yes, of course it's interesting to have waiting time if you have a disease, for example, a serious cardiac disease that you know that if you wait long, you may die just waiting. But most of the time, waiting time is not that important, because if you see the patient, give them a correct diagnosis and say, this is not dangerous, but we will help you with this within the next 6 months, people are happy with that. So waiting time in itself is not important. It's just important in certain instances, and you have to have the knowledge in order to interpret that. The patient, she wants to know whether she's going to survive. When is she coming back to her normal life? Can she undergo the treatment, or is it too tough to take all the chemotherapies? Those are the questions the patients want answers for. And most of the time, we as hospital managers or doctors or nurses don't have the answers because we don't measure what's important to patients. And this is what we learned the hard way starting. And this is what takes time with value-based healthcare. You have to get all the medical professions to start thinking in a new way. what's important to the patients and not the organization. But if you get over that hurdle, things happen almost by itself, because if you start measuring outcomes that matter to patients, you can measure your success. And if you can measure your success, you feel good about going to work, you feel good about improving. In order to do this, you have to collaborate, because no doctor, no matter how brilliant they are, can do this on their own. I'm an IVF doctor. I do test tube babies. That's not what doctors are the best of. I could not do anything without my lab technicians that are actually doing the embryos for me. And if you start doing high-quality healthcare, you do cut cost immediately, because you don't have to do it twice, and you don't have to do lots of unnecessary steps. You save money by doing the correct thing at the right time. This is a picture that also took some time. You have, if we now measure these outcomes, we know that we measure the right outcomes, and we want to publish them. You have to have trust in the organization in order to publish. Because if your staff don't believe you as managers, that they won't be punished if they publish poor results, you're not going to get the true results. You have to get that trust and tell them that, yes, I know that your results are not probably top-notch, but you are working on them, and I want to see the correct results, and I won't punish anybody. It took some time in order to be able to have the trust of publishing your result transparently. And that's what managers should do. Never, ever punish. Keep the trust going, because then you get the gold mine of knowing what you do, and you can change things. And this also goes for publishing nationwide. In Sweden, we publish different departments, but not individuals. I know in Great Britain, they publish the results for individual doctors. And that can mean that the individual doctors actually don't accept the hardest cases, because they don't want to go down in their own individual ranking. That's a very dangerous slope, and it's not built by trust. I think this will be very complicated in the future, because all the consumer organizations will publish individual results whether we like it or not. So we have to be very smart and figure this out. I think that iCHOM is one way of helping us with this, because iCHOM outcomes does not give any, it makes it possible for us to compare organizations instead of individuals, and stresses the team effort. And I think that if we would use iCHOM's measures, we would get away from these penalizing effects of producing outcomes. Okay, I better speed up a little bit. But what happened when we started? Well, after 1 year, these are the 5 first groups that started. After 1 year, the orthopedic surgeons and their colleagues increased the number of hip surgeries by 36% within the same budget as they had before, which means they increased the volume. This is a value add. They also reduced the adverse events by almost 20%. So risk reduction, that's a value add. The psychiatrist chose bipolar disease as their condition, and I will talk a little bit more about that. They could reduce the length of stay by 30% within the budget, which means that they could do a lot of other improvement, and I will talk a little bit about that. When it comes to osteoporosis, they could increase the coverage of preventive efforts to 85% coverage, which is a huge improvement and a huge saving for society. The normal birth group could reduce the C-section rate, which is a risk reduction for both mother and child. And the prostate cancer group could increase the continency after surgery, and that's an outcome improvement. So you can see all of them produce values, added values, but they chose different things to work with. And that's how it should be, I think, because they have to have great autonomy in doing this because they know best. We as managers could only support them. They would come to us. We would have once a month a meeting with the high top management where they would tell, okay, we need this and we need that and we need a new wall or a new legislation or whatever. That's what managers are for. Not telling them what to do, but just supporting them to do the right thing and follow up results. Long-term results take a little longer, obviously. We could see that the employment rate increased, especially for the psychiatry patients, which is a huge saving for society, not to say for the individual who could actually keep up a job. We could also see, as you see further down there, the sense of purpose for our staff increased. They felt that they were doing the right things. Instead of saving money or cutting cost or whatever they were doing, they were actually working for their patients. And the sense of purpose and the contentment among the staff was tangible. We have waiting lists of people coming in now to work in those groups that have started. We have no recruitment problems whatsoever. I will now take you even further down in the organization and follow the psychiatric team that chose bipolar disease as the first condition to work with. So I will spend a little time on that. And just to show you that if you start working with one condition and the full cycle of care, you change your perspective of what you do. And they did. So they could see that there are two wards adjacent to each other. The staff in the two wards know each other, but if you were a patient with bipolar disease, you had to stay 30% longer in one ward to get well and go home than in the other ward. Why was that? Nobody had seen that before because we just measured the length of stay for all psychiatric patients. Now we measured for a specific condition, and we could see this big difference. So the two wards sat down together and said, okay, why is this? And they could see that they didn't have any standardized care. They did a little bit of that, a little bit of that. It depended on who was at work that day, and you know, things were very variable. So they got together and sat down and produced a standardized path of care for these patients at this hospital. And that made that the two different wards that had 30% difference in length of stay evened out and got the same length of stay, and collectively they saved about 30% of length of stay. So now they had resources that they could use for other things. So what did they do? Well, the patient said that, you know, when I have my relapse in my bipolar disease, you know, they become suicidal. It's really a dangerous condition to have. I want to be sure that you always have an empty bed for me when I call the hospital, because you don't always have that now. So they used that extra space to always have an empty bed for the patients, which meant, together with the standardized care, always an empty bed, that the patient felt safer and knew that I will always get help when I need it. I don't have to wait for help, which meant that I came even less, there were even less need for inpatient care. And what did happen was also that the standardized care reduced the number of relapses by about 10% during the course of a year, which is pretty good in a chronic disease, I say. And when you calculate how much that meant in money for us, meant that 180 less patients had to be hospitalized. They could be at home, tending to their daily business, taking care of their children or going to school or whatever they were doing. And we could save some 24 million Swedish krona, which is about, you know, 2 million euro, just by doing that. So things happen, and they happen very quickly. And after this, they started doing research on this. So now we have 6 PhD students studying on how to improve care. And as I said, we had a hard time getting psychiatrists to the hospital before. Now we have a waiting list for psychiatrists to come in and work for us. So if I summarize make a short summary of measuring outcomes, I would say that you focus on what's important and you align all the stakeholders in the healthcare. So everybody is going for the same goals, and the patient become the center and not the hospital. This is my last picture, and it's a picture from what I've been doing the last 18 months. I've been producing public health care in one of the little emirates in the United Arab Emirates in the Middle East. And this is an example that value-based healthcare works there too, because this is the diabetic center. And the UAE has a very tough burden when it comes to diabetes. 25% of the population has diabetes. So this is a major issue for them. This is what my team did as an outreach day. And they, as you can see, collaborate very closely with their patients. And your life, your choice, eat right and be active. That's telling the patient that you are the runner of your own disease. We are not, we're just helping. And this is about all the Russians I know. Thank you.
Спасибо большое, Барбро. У меня есть один вопрос, который хочет задать Штефан Тушин. Пожалуйста.
Barbro, thanks a lot for the presentation, sharing the experience. It's amazing to see what the team achieved also by minor measures and improvement, right? So, what has been, from your experience, the top 2, 3 hurdles to implement this? So what has been really the difficulties to overcome?
Actually,
Perhaps
trust.
the microphone.
That's a very good question. Trust is one of them. But also, you have to make them make your staff understand that you do trust them. They know what's going on at the department around the patients. They communicate with, they have the deep knowledge of what's going on, and they have to trust you as a manager to only support them, not punish them. That was one of the hurdles. You have to build trust. So I was out talking all the time, and I always said the same message, so eventually I won their trust. Secondly, it has to be something for them, and I think Martin said it very clearly, you have to tap in what's important to them, and to me, I have the same experience, Martin. Everybody who works in healthcare, they chose to go to medical school or nursing school because they wanted to help their fellow human being. They want to do good. And you have to tap into that passion. And we had to align their rewards into that passion. And thirdly, after a while, when you start working with this, you have to reorganize your hospital. You cannot continue having the same old departments doing whatever hospitals do best. You have to reorganize it along the conditions. And that was a big hurdle, and I only got started with that, and I know Karolinska is working with it. And in my view, I think you have to do that as an evolutionary process that will take time, but you do have to reorganize the hospital along the conditions instead of having them in surgery or internal medicine or whatever.
Большое спасибо.